There, this is Laura Heffern. I'm a family nurse practitioner student, and I'm going to share about Turner's syndrome and in the presence of a 13-year-old presenting to the primary care clinic with Turner's syndrome already diagnosed with a new complaint of chest pain. So let's get started. Okay, so chief complaint, chest pain. History of chief complaint. Sarah presents to the primary care clinic with her mother, and she states that she started having mid-sternal chest pain yesterday during a volleyball game when a volleyball was spiked from the other side of the net and hit her in the chest. She immediately left the game, sat on the sidelines, and had 8 out of 10 pain at that time, but it improved enough that she was able to go out to dinner with the team after the game. Overnight and this morning, she's continued with intermittent chest pains in that mid-sternal region, about 7 out of 10 pain. She describes them as cramping and stabbing. They aren't radiating anywhere, and it's anywhere from 5 to 7 out of 10 on a 1 to 10 pain scale. Again, no treatments have been given for this pain. She hasn't tried any medicine, any ice or heat to alleviate it. Moving on to her past medical history and description of her needs with her syndrome. Okay, so she has Turner's syndrome, and this is a complete or partial loss of her second X, which we'll go over more in detail in a minute. So girls with Turner's syndrome can expect growth delays. They can expect amenorrhea and not hitting puberty. Other things that often accompany this syndrome include cardiac lesions like bicuspid aortic valve, as well as coarctation of the aorta. And then they can have kidney problems like a horseshoe kidney, agenesis of a kidney, and a fatty liver disease. They also have some physical abnormalities with their neck and their ears, which we'll discuss. But in general, these women aren't intellectually delayed, and it's quite possible that from the layperson's eyes, they wouldn't pick them out of a crowd. Very likely that we all sat in class with women with Turner syndrome, have jobs with these women, and they get along in society very well with minimal disruptions to their lives compared to some of these other kids with special health care needs. However, let's keep in mind those growth delays, the in-functioning ovaries, cardiac lesions, and the kidney and the liver problems. So what causes Turner's disease or Turner's syndrome? It is the lack of a second X. So as we all know, women have their genetic chromosomes as a double X. But with Turner's syndrome, these women are missing that second X or partially missing that second X. In fact, the partial is more common. Actually, there's been a lot of studies that a complete deletion of the X results in a lot of miscarriages. So the fetuses that make it to birth often have a partial deletion of that second X. The deletion of that genetic material leads to these problems that we discussed: the ovarian failure, the growth delay, fatty liver, kidney problems, and the physical differences. So let's get back to Sarah, our patient. Again, she's a 13-year-old presenting with chest pain. She, as far as past medical history goes, she has a diagnosis of Turner's syndrome. She has had a history of frequent ear infections, another commonality with kids with this syndrome, which she did have hearing loss, but it has resolved, and she did go through speech therapy, but she's graduated, which is great. Other history, she does have a history of a supracondylar fracture requiring an open reduction, so she has that on her surgical history. Otherwise, no issues. Socially, she lives in adequate housing with her mother and her father and her 2 brothers. She attends school, the public school, normal classes, makes mostly B's. And otherwise, she's been a healthy girl. She reports no alcohol use, denies drug use, denies any sexual contact. So for her review of systems, okay, so I'm thinking chest pain, definitely going to ask about cardiac, I'm going to ask about respiratory, probably going to ask a few GU questions, neuro questions. So her review of system reveals that she has no dizziness, no syncope. Moving down to respiratory, she denies cough, congestion, sputum, any spitting of blood. Cardiac, she reports that chest pain that I described in the HPI, but denies any loss of consciousness, any syncope, any tingling of her hands or toes, any cyanosis. MSK, she denies any pain anywhere else on her body besides that mid-sternal area. And GU, she is peeing normally. She is taking her medicines as prescribed. And, I'm going to do thyroid too because these women often are prone to some endocrine issues, but she denies excessive thirst. She denies heat intolerance or cold intolerance, any constipation, slowed speech, anything like that. So let's move on to her physical exam. For Sarah, with her HEENT, I'm noticing the normal, what I always see when Sarah comes to the visit. She has the characteristic kind of web neck, they call it. She has low ears. She has a hairline that comes a little bit lower than the other 13-year-old girls that we see in the clinic. She has a wide nipple line and a delayed puberty. She has shorter stature, and we chart her growth on a Turner syndrome chart rather than the charts we use for everybody else. Her vital signs look stable to me. She has a heart rate of 85. Her blood pressure is 110/80 in her arms sitting. She's breathing an easy 16 per minute without any retractions. Her temp is fine. A febrile at 37 Celsius. And her SpO2, we'll check that too, is 96%. Moving on back to her physical exam, again, the webbed neck, the low set ears, the low hairline. We will do a respiratory and cardiac exam. Her lung fields are clear to auscultation. She has normal expansion of her lungs, no cough. I hear S1, S2 without any murmurs or clicks in all 5 areas for the cardiac exam. Strong pulses radially and femoral pulses are normal. She is pink, warm, and dry throughout. Other exams, I'm just going to do a brief MSK as well, take a peek at all the rest of her joints, make sure there's no other issues. She has full range of motion of all her joints. She's walking without a limp. I take a look at her chest, and there's no deformities to her ribs. She does have that point tenderness mid-sternally, but otherwise, her ribs look good. There's no bruising at the site of the volleyball where the volleyball hit her. I'm going to skip GI, I'm going to skip GU, and just continue on from there. For her differential diagnosis, I have costochondritis, and I have cardiac anomalies that may have gone undiagnosed. So for my plan, I want to go ahead and get an EKG now. I am going to give ibuprofen now. And see if the EKG reveals anything that needs to go to the ER or if her ibuprofen improves her chest pain. I'm also going to go ahead and schedule a cardiac MRI and a cardiac echo and a cardiologist appointment for her. So it's important to remember that she is a Turner syndrome and we need to be following her cardiac history, and with chest pain, I need to rule these out. That's why it's important to get the cardiac imaging. Research shows they need an MRI and an echo, but I'm not worried about fractures because she's on that growth hormone and the transdermal estrogen, so she's not more at risk for fractures than other women. That's what the research shows. So again, because of her history, I need to be more careful with chest pain, get that cardiac imaging, and she needs to go to the ER if she has any increased chest pain, syncope, dizziness, or pain that doesn't go away with ibuprofen. All right, thank you.